so much, Mindy. It's really great to be here. And I appreciate you all taking the time out of your day to come to this talk. So I'm really excited. I learned a lot myself researching this, and I'll try to give you my perspective as a urologist in different diseases, especially as they relate to Parkinson's. So I have to start with my disclaimers. I'm a urologist, so my focus is on genitourinary diseases. So that's both kidneys, the ureter, the bladder, the urinary tract, and also specifically men's sexual health. It's different from some other specialists. Sometimes people don't always make the distinction. I'm certainly not a neurologist, and I won't pretend to be, but I do treat a lot of patients with neurological disease and have at least some expertise in how that relates to the urinary tract. And I'm not a nephrologist. So nephrologists, those would be, medical kidney specialists, people focusing on chronic kidney disease, end-stage renal disease, dialysis, things like that. So my focus, as far as the kidneys are concerned, are mostly on surgical diseases, things like kidney stones. I will mention a lot of different products today, different brands and companies that create these products. I don't have any financial disclosures. I use them and I believe in them because they work. And so I don't have any specific, reason that I would recommend anything today, other than the fact that they're effective. And lastly, this is an educational talk. Hopefully we can kind of inform you on different things that are things you might want to look into. But at the end of the day, I would encourage you to talk to your doctor, get a referral and see the appropriate specialist. So I put this slide up here just to show how complicated Parkinson's disease can be. I will not pretend to understand or act like I understand everything going on here, but I just wanted to focus on a few things, which is that the brain and the urinary tract are very closely linked. So in the same way that Parkinson's affects the neurons in the brain, the dopaminergic signals and things that affect movement, that actually affects your bladder, that affects your urethra, that affects those things in a very similar way. So a lot of the sort of classic Parkinson's symptoms certainly mirror what happens in the urinary tract. And we'll kind of delve into what this might look like, in clinical practice. But suffice to say, it's a complex topic, research being done, and something that we'll continue to learn about throughout the years here. So Parkinson's disease, very, very closely linked with urinary tract symptoms. I think if you really poll anybody in this age range where Parkinson's is common, you will find that most people have some type of urinary symptom. Doesn't bother everybody, but what we found is that in Parkinson's specifically, these symptoms tend to be a bit more common. And you can see here that incidence or frequency could be as high as 60 or 70% of people out there with Parkinson's disease. What we found is that the signaling sort of alterations, again, they affect the bladder, the urethra, the sphincter in different ways and essentially lead to a whole host of urinary symptoms. I'm sure these, would be familiar things to some people out there, but the most common ones we find are what we would sort of classically call overactive bladder or storage symptoms. And so these are things like urgency, feeling like you got to run to the bathroom, or when you got to go, you got to go. And sometimes if people can't control their urine, they have leakage episodes. Other things we sometimes find are just, frequency, feeling like you got to urinate all throughout the day, feel like you're getting up at night all the time to pee. And so none of these are really, I would say, unique to Parkinson's disease, but they're really commonly seen in that population. So one of the most important things I would say as a urologist is that because this is so complicated, a lot of times we do need additional testing to really understand what's happening. There's a very common test we do in the office. It's called a urodynamics test. It's quite complicated. It involves a 1 or 2 hour visit with one of our nursing staff, multiple catheters, and we're basically almost putting your bladder in a lab environment. We're filling it up. We're seeing what the pressures are, how much urine you hold, how does your sphincter react when you pee, how much pressure flow you create. And the purpose of that is really to understand, what is sort of the health of your bladder and how is Parkinson's or say some other neurological disease affecting that? So I put these findings here really just as it's more just kind of medical lingo, but there's a number of findings that are associated with Parkinson's disease and other neurological diseases. And these are sometimes things we look for to really understand what's happening. So this type of testing is, done at a urology office. And I think for a lot of complex patients where we're concerned there might be multiple things at play, it can be helpful to have these things done. One thing I want to say is before I go any further, I did want to make this interactive. So if anyone has questions anytime, please feel free to raise your hand. I'm happy to try to answer them. I think it might be easier if we just sort of answer them as we go along here. And on Zoom as well. One of the most challenging things that we find is that there's not really specific treatments that are targeted towards urinary symptoms related to Parkinson's disease. Most of what I'm going to talk about in the next few slides here actually really applies to anybody presenting to the office with these symptoms. And so as it pertains to Parkinson's, there's not much evidence on what's helpful. It's thought that trying to restore, the same treatments that are useful to kind of help with the motor symptoms might be helpful for urinary tract symptoms, but I think the jury's still out. I'd certainly be curious to hear if anybody out there has experience with this to see if their symptoms got better with some of these therapies. The ones that are common are going to be your dopaminergic drugs, levodopa, carbidopa, those sorts of things, and then one of the articles I looked at sort of talked about whether deep brain stimulation might help with that, but I think a lot of this is a little bit preliminary. So this is kind of the crux of my talk, is really focusing on a whole host of urinary conditions that I would say almost overlap with Parkinson's disease to the point where sometimes it's actually quite hard to distinguish, what's related to Parkinson's and what's just something that's common. I would say in terms of these, I in some sense listed them in terms of sort of how the frequency that they occur, but overactive bladder is one of the most common things that I as a urologist treat, and fortunately a lot of the treatments I think will be helpful for patients in the Parkinson's population. So we're going to focus on that first. So overactive bladder, this is just a common definition that's used, and really you'll see that when you think back to the other slide, these are the exact same symptoms that we associate with Parkinson's disease. So it's urgency, running to the bathroom, frequency, urinary incontinence or involuntary leakage of urine, and then also getting up at night. So these types of symptoms, it's quite hard in practice to distinguish the two, and we again sort of treat them sometimes as one entity. Now, the most important thing when I think about treating these symptoms, number one, is understanding how bothersome are they. And I found it's quite interesting because patients seem to, respond to things differently. For some people, getting up twice at night is the worst thing in the world. But for other people, they get up 5 times at night and it's been going on for 20 years and doesn't really bother them. So, I think that's kind of the most important thing is, how much does your symptoms bother you and how sort of, I guess, invasive or how much therapy do you want to undergo to try to make them better? Anytime we see patients in the office, the goal is always, how do we get the symptoms better without medications, without surgery, without anything? And that's always going to be kind of your behavioral therapies. And I'll be honest with you, sometimes that can only sort of get you so far, but some of the more common things I see is people getting up 3-4 times a night, and it turns out they're chugging a glass of water before bed. So, these are simple things that you sometimes don't think about because they're habits, but they can certainly make a difference. Other things that I sometimes find helpful, people tend to want to hold their urine. They don't really go till they have to go, but it can be helpful to actually urinate at regular intervals. Keep your bladder empty and sort of avoid having those, quick urges where you just have to run to the bathroom. There's a whole host of other things that get, fairly complicated, but suffice to say that, it's always good to explore these options and see if they're helpful to you. But kind of going to what I would say is sort of the mainstay of urology in terms of treating these symptoms are going to be medications. And some of these may have been ones that you've actually seen before. Classically, we used to prescribe these medications up here. They're called antimuscarinics, but essentially what they do is relax your bladder and sort of inhibit the bladder's ability to contract. And sort of the net result of that is you're able to hold your urine better, the urges go away, less getting up at night. One of the problems I would say with these older medications is that they do have side effects. In fact, some of them are actually linked to cognitive side effects. So in that sense, I do tend to avoid them. They tend to also have other side effects, constipation, dry mouth, dry eyes. So this class of medication up here, in my opinion, has kind of fallen a little bit out of favor. And I oftentimes don't recommend taking them, except the only reason I sometimes will have people take them is because, unfortunately, to get certain therapies approved, we have to sort of demonstrate or show that these are not appropriate therapies. So that's usually the only reason I would be prescribing these. The medications I actually recommend are a bit of a newer class of medication. They're called beta-3 agonists. They just work on the bladder a little bit differently, help relax the bladder. And the ones that you'll probably hear about in the office are ones called Myrbetriq and Gemtesa. Those are the brand names, but you can see the generics here as well. These are the ones I really recommend to people. They really don't have many negative side effects. So I think for a patient coming to my office with kind of this new onset overactive bladder type symptoms, regardless of whether or not there's other coexisting diseases like Parkinson's, I think it's worth a shot to try one of these medications and see if you tolerate them. But of course, medications are medications. There are some interactions, there are some side effects that people develop. So we always have to be careful in when we add these to somebody's medication list. So this segues, I would say, into kind of the more maybe interesting part of the talk, which is, what do we do when we can't get the symptoms better on just medications? We can't get the symptoms better with sort of these non-invasive things. And this is, what I would say is a mainstay of therapy in overactive bladder. And I would say all of these actually would apply to patients with Parkinson's disease. We did hear some interest in this first one, percutaneous tibial nerve stimulation. So I'll talk about that first, but then we'll talk about a couple other ones as well. So this is a really interesting therapy. It's called PTNS, or percutaneous tibial nerve stimulation. The company we use is Labary, and they have a product called Urgent PC, and that's the one that I've sort of put some diagrams of here. But essentially the way it works is we put a small, tiny little needle in the ankle, which actually stimulates a nerve that connects all the way up to where the sacrum is, essentially where an area that actually controls your bladder. So just by stimulating that nerve, we're actually kind of altering the nerve signals that travel to the bladder, travel to the brain, and actually kind of sort of inhibits or kind of tones down the bladder's ability to squeeze and go crazy all the time. I think it's a really great therapy because it's non-invasive. There's almost no risk, but I would say anytime you stick a needle in anything, there's obviously going to be some risk of bleeding, risk of, local reactions. But so far, I've not really had any issues with that. The way it works is you basically come into the office once a week for 12 weeks. So you just sit on a table, kind of like this lady over here, read your book, and just kind of stick your leg up, and we'll get the therapy going. And you sit there for 30 minutes. You feel a little bit of tingling kind of in your legs and your feet. Some people can get some sort of toe contractions and foot contractions, but we sort of set you at a level where it's not too uncomfortable. And again, if you get good benefit about halfway through, it usually takes about 6 sessions to show some benefit. Potentially, we can get people on sort of a maintenance therapy. So I think this is a really great therapy for patients that really don't want to introduce any additional risk and have the time and the ability to come to the clinic frequently. But again, that means the downsides are you got to come frequently. Does not interfere with neuropathy, but if you have some kind of pre-existing significant nerve damage or nerve injury, I would say the therapy may not work very well. I don't think there's evidence to suggest that it would make the neuropathy worse, if that would be your concern, but there is a relative contraindication if you've got sort of pre-existing severe neuropathy, so that would be a consideration. The other thing would be pacemakers. That would be another contraindication, a cardiac pacemaker. So that kind of takes me to another really popular therapy, which is Botox, or onabotulinum toxin. I think everybody kind of knows Botox because it paralyzes the wrinkles in your face. And the way it does that is it just paralyzes the muscles. So believe it or not, they kind of figured out you can put Botox in basically anything. So we've basically figured out over the years that it works in the bladder. And it does the exact same thing. You basically inject it directly into the bladder wall, it paralyzes some of the muscles. So the bladder can't really contract as much. So the net result is you don't pee as much, you have less urgency. Now, one of the problems with Botox is sometimes it just works too well. So there's this risk of urinary retention where you can't pee at all. So we have to be very careful with this type of medication. I don't think everybody's going to be a good candidate for it. I especially sort of caution it in men just because men tend to have a large prostate. They sometimes have a hard time peeing to begin with. So we put some Botox in there and suddenly they can't pee at all. So we have to be very careful about that. It's a very quick office procedure, requires just a little flexible camera that we stick in to the urethra where you pee from. And that's done with some numbing gel. So it's not comfortable, but I would say for most people it's tolerable. It's not the most pleasant thing you'll go through in the world, but certainly something that most patients can tolerate without any other anesthetics. But for people that find that sort of concept a little bit scary, we have different ways to do anesthesia. We can even do it in the operating room if somebody's concerned about that. One of the downsides with Botox is it's not permanent, so it's only going to last about 6 months total. Some people need it more frequently, every 3 months. Some people, they respond well. We do it every 12 months. But unfortunately, it does involve redosing that and coming back into the office for that. But I would say I certainly have a lot of patients that are very happy on Botox. And so I think if you've exhausted some of the other therapies, it's definitely one that I think is worth considering. And finally, sort of the last thing I wanted to talk about is a device called a Medtronic InterStim. This is sacral neuromodulation. So kind of in the same way that the tibial nerve stimulator sort of affected the nerves that go to the bladder. It's a very similar type of technology, except we're stimulating nerves in that sacrum area near the bladder directly. So I think this is a really great technology, but I would say it's a little bit more invasive than the ones I talked about. Ultimately, what we do is 2 parts. We basically bring in the first part for just a quick test. So we just lay on your tummy, numb your back up, and we put a little temporary test device. It's not this one, that's the permanent device, but a little test device that you just kind of wear as a belt for a week. And so that one, if you find that it's very helpful, we actually end up basically a few weeks later putting that permanent implant in, and it just kind of sits in your upper butt area. So for most people, it's not too bothersome. It's that one back there, the kind of a bigger looking coin that we just put in there. So I think this is a great therapy because it can be a very good long-term option. If it works, that battery there can actually last 10 or more years. And it's got sort of its own little programmable device. So it's something where you have to be a little bit tech savvy, somebody who's interested in kind of participating in the therapy and making adjustments. But have a lot of patients who are very happy with it. And once you kind of get it going and get it dialed into where you want it, can be very, very effective long-term. So this is another one I think is worth considering. But again, it's a small surgery. So I think for people that are sort of averse to that, might want to consider some of the other therapies we talked about. So I'm going to segue a little bit to sort of a totally different topic. Before I get into that, is there any questions about just overactive bladder treatments? Everything I've sort of talked about has been focused on that. And again, I've sort of moved away specifically from Parkinson's disease, but I want to say that almost all these therapies could be effective in that setting. And so questions about really any of that or how that would, yes.
What are the side effects of the medication?
So
the lower bracket that you suggested.
Yeah, the medication side effects for these newer medications, the mirabegrant or Ribetric is known to possibly increase blood pressure a little bit. That's the only side effect I usually counsel patients on. Otherwise, the one below it, Viagra or Gemtesa, really doesn't have any side effects that I talk about to patients. It's very rare unless somebody has an allergic reaction or some kind of interaction that I ever really hear of any issues with taking the medication. So yeah, but for that top one, I wouldn't want to prescribe this Myrbetriq or Mirabegron to somebody with sort of uncontrolled high blood pressure. That would be one of the contraindications, but otherwise they're very well tolerated. So I don't, honestly, I usually don't really specifically talk about any side effects with these.
Do you generally start with the medication before you use any of the other processes?
In general, yes. And I think a little bit of that is just patient preference. Most people want to trial a medication first and are willing to, just because it's a little bit lower risk, a little bit less committal than doing a procedure outright. So I would say that's my typical approach, is that most people I would offer a medication first. But if somebody came in and said, I really don't want to do medications, I want to try something that's some other type of therapy like the ones we mentioned, then, as long as we can get those covered and approved, we certainly try to just, potentially go straight to those.
I have a question. I am wondering, in terms of insurance, are any of these considered experimental? And what is the insurance in general coverage for these procedures?
None of these are Oh, yeah, absolutely. So the question was, are any of these experimental treatments or considered experimental, and what the coverage is insurance-wise? No, so these are all approved. So none of these are experimental. And insurance, in my experience, will cover all of these, but sometimes I do find that they do want certain therapies before, and oftentimes because for insurance companies, these older medications are the cheapest options. A lot of times they do want you to take these first, and so it becomes a little bit of a conundrum because it's not always the easiest to sort of navigate through that process. But I would say for a lot of patients, once you fail or don't have effectiveness for at least one of these either class of medications, they tend to be covered for those procedures. And there's no reason why you couldn't go to the procedures outright without medications. Some, insurances will just cover these if you have the symptoms. So it's your mileage may vary. Every insurance company is a bit different on how they approach things. Some can be more challenging than others to navigate, but you don't really know until you try. So that's the challenging part.
Thank you.
Of course. Other questions? So I'm going to focus and segue a little bit to a different entity that is going to be very common in the population of patients with Parkinson's disease, and that's going to be BPH, or benign prostatic hyperplasia. So this is something that affects men with age, and unfortunately, as we age, our prostate tends to grow, and the prostate grows inward. So it essentially obstructs your ability to urinate and obstructs your flow. So most people who present to the office with urinary symptoms are going to come in with symptoms of a slow or a weak stream, or feel like they don't empty their bladder all the way, or they're straining to have to urinate. And what we find is that, this is very common outside of the world of Parkinson's disease, but within Parkinson's disease, it's probably even more common because of the effect of the the effect on the nerves as they relate to the bladder and relate to the sphincter. What we've seen is that patients with Parkinson's disease sometimes have a hard time relaxing their sphincter, so things can be a bit delayed. So they have sort of this obstruction to pee, and that's compounded by the fact that there could be some underlying enlargement of the prostate as well. Diagnosing this can be a bit complicated. One of the things we like to rely on are going to be surveys or symptom scores. There's a couple out there, IPSS and AUA, which is the American Urological Association symptom score. And you'll see, again, that same types of symptoms that we talked about, urgency, frequency, nocturia, getting up at night. We kind of see that all of these different disease entities overlap in how they present. And so our goal really is how do we or how do I, in my mind, separate them and decide sort of what's best for each person here. There's a lot of different things that I recommend that you might, if you came into the office with these types of symptoms, these are the kinds of things we might recommend for you. Number one, I usually recommend at least men in sort of the 50 to 70 age range. If you haven't had a PSA screen testing, that's an important thing. This is kind of a tangent, but I think screening for prostate cancer through PSA, which is a blood test, is very important. And so it's something that if you haven't had it done yet, it's definitely worthwhile, just because sometimes we can detect prostate cancers when they're early and treat them if appropriate. That PSA number also sort of correlates with how big the prostate is. The more bigger your prostate is, the more of that PSA sometimes you'll make. So it's a very important test. The other thing that's important, and this is going to be another bit of a tangent, is something called a post-void residual. There are a lot of patients out there, especially with Parkinson's, who may not empty their bladder well. And so the way we identify that is by checking, we have a little bladder scanner that basically is an ultrasound and lets us see how much urine are you holding in there. So if you're retaining a large amount of urine, that really changes the way that we, treat symptoms. And so that's an important thing as well. I included a couple other things, cystoscopy and an ultrasound. These are a bit more advanced, but sometimes we just have to look in there to really understand what's happening. So treatment of benign prostatic hyperplasia, or BPH, is a little bit different. These medications and these types of things are sort of unique to this entity. But a lot of patients I have really are on treatment for both things. They might have some overactive bladder, they might have some enlarged prostate, there might be on both types of medications at the same time. So a lot of these medications, for example, the tamsulosin, or what people commonly know as Flomax, is very commonly prescribed by primary care doctors. A lot of patients come into my office already taking this, but I think it's important to know that these types of medications can be helpful, though they do have side effects. So it's oftentimes important for us to talk about that. Surgery is a little bit different for this. A lot of patients who have an inability to pee from their prostate may ultimately require surgery, and that can be a bit more complicated when we talk about having Parkinson's disease. The most common one that you're all perhaps familiar with is called a TURP, or a transurethral resection of the prostate, what they kind of used to call the roto-rooter. A lot of people used to have this type of surgery. It's still around in sort of a different form. But we have to be careful. Not every patient with Parkinson's disease is going to be a good candidate for this. And this is kind of where that urodynamic study that I talked about earlier could be helpful.
Excuse me, why wouldn't it be? What are the contraindications for Parkinson's people?
Well, one of the issues is, what is sort of the underlying reason for the symptoms? And if the underlying reason is, say, the bladder doesn't squeeze well, then if we open up this channel with a surgery, we may not actually be helping the issue. We might actually be we might be helping the ability for the urine to escape or flow out. But, for example, if the majority of the symptoms are overactivity, urgency, frequency, sort of something related more to the bladder, we may not actually be addressing that. So it could be a bit complicated. And I think, this is where kind of each person is a little bit different. You gotta tailor the treatment, tailor the workup to each person.
Thank you.
So last slide that I have as it relates to urination is this one right here. And I think, urinary tract infections are really challenging to deal with really in any patient population, but I think especially in Parkinson's, that's the case. There's some data that suggests that patients with Parkinson's are about twice as likely to be admitted to the hospital with issues related to a UTI. There's some evidence that shows that UTIs can actually exacerbate the motor symptoms, exacerbate all of the symptoms of Parkinson's. So it can be a really challenging entity. And this is a diagram from a article that I found that I think really kind of summarizes the difficulty. The challenges of sort of managing patients with bad urinary tract symptoms and difficulty with mobility. All these things just compound on each other and ultimately can be quite difficult. And so there's a lot of strategies out there to reduce risk of UTIs. The ones that I think are most important that we sometimes overlook are simply hydration. Being dehydrated really affects your bladder's ability to empty out all the bad urine, the bacteria. There can get, stagnant urine that grows and bacteria grows and you get UTIs. So hydration is important, flushing out all that bad bacteria. And I think for a lot of patients, that can ultimately end up being one of the things you can actually control. And unfortunately, a lot of the other things are out of your control. How your bladder behaves, everything else is stuff that, we have to try to figure out, try to optimize. But I think, urinary tract infections in particular, really can affect everybody, and it's quite challenging. And there's a lot of strategies, but they get, increasingly more invasive. And, we really don't want to keep people on antibiotics all the time. Our goal is really to try to avoid UTIs, and there are some supplements out there, things you may have heard of, things like cranberry pills that can be very helpful. So anytime a patient comes to the office, I always talk to them about different non-pharmacological ways for us to be able to reduce that risk. Yeah.
Those be good for men and women?
Yes.
And manos with cranberry?
Yes, I think both of those would be good for men and women. I think they're very low risk. Unfortunately, you gotta buy them, but they're, as long as you find a good brand, they really shouldn't have any side effects. They're pretty well tolerated. You just have to be consistent with taking them. Yeah.
Thank you.
So there's a lot of, this could be sort of its own talk, and I'm certainly happy to answer any questions sort of more involved with that. But I just wanted to bring that up because I think, urinary tract infections for everybody can be frustrating. And so I do want to let you know there are a lot of things we can do for that. And so we shouldn't kind of get in this cycle of just UTI treated with antibiotics, UTI treated with antibiotics. We should really try to understand what the root cause is and see if we can make that better. But that's really kind of the crux of my talk.
We have a question.
Oh, yeah, absolutely.
There's a question online about you had a picture of the salt palmetto for the benign prostatic hyperplasia. Could you explain the salt palmetto? Because I know that's available at Costco and everywhere else and promoted quite a bit.
Yeah, funnily enough, I just picked that as a free stock photo because I have to use non-copyrighted pictures. But salt palmetto is very commonly sort of known supplement that's thought to be helpful in BPH. I'll be honest, I don't know a whole lot about the actual evidence behind it. I can say sort of anecdotally, I've had a lot of patients take it and had success. But if you came into my office and asked me, what do I recommend? I wouldn't say I necessarily recommend it. I don't think it's harmful. So if you wanted to try something that's non-medication, something a little bit different, I think it's very reasonable to try that. But I don't think it's going to be a slam dunk. So I think it's maybe might have some modest benefit, but certainly probably not harmful. So certainly something you can consider.
Thank you.
So this is kind of the summary. I just wanted to focus on a couple of things. One is that, diseases like Parkinson's are just so complicated, and there's so much we don't really understand, that I certainly don't understand, but I'm sure neurologists are still trying to understand about the disease. But it is important to know that, a lot of patients are sort of suffering from urologic issues, urinary tract symptoms, and perhaps just kind of getting used to them, not really sort of addressing them. So, I would say if you're somebody out there or knows somebody that's really hasn't sort of reflected on how bothered they are by some of these symptoms, I think that's a good idea. And certainly it's worthwhile to investigate and look into some of these therapies because you don't really know what it's like until you treat it, right? We just kind of get used to living the life that we're living. And so I think it's a good idea to just sort of reflect on that and think about whether or not, there could be some improvement or you are, quite bothered by something. And then last thing is, individually tailored treatment is so important. All of these, it's sort of like a Venn diagram where almost everything overlaps to some degree. So my job and sort of all your doctor's jobs is sort of figure out where do you sort of fit in that picture and how can we help you, improve those symptoms, improve your quality of life. Most of these are not life-threatening things, but they certainly are, can be quite damaging. So I think it's important to think about, what's the best approach for you, I guess you could say. I have a few other slides. I don't know if we want to get into those or just sort of go into a Q&A or what do you think is best?
Let's check with the Zoom. I don't know if everybody on Zoom knows you can hover down at the bottom of your screen and click on Q&A if you have questions and type them there. If anybody has questions, you can type them there. Otherwise, I'd say go on to those supplemental topics.
Bonus slides. So I think, one thing that we tend to not talk about really in our society is sort of sexual dysfunction. And again, it's not just Parkinson's disease, but it's very common in Parkinson's disease. So I think it's important to address. I don't think that, I don't think we quite have the robust research to tell us that, the disease itself is causing these problems. It's possible they just sort of coexist as we age and things like that. But certainly, patients coming in with sexual dysfunction that's not addressed are going to have, potentially other things like depression and relationship problems. So I think it's worth at least having a conversation if that's something that's important to you and something you haven't addressed, and thinking about whether that's, whether there's something that can be done. In men, we commonly treat erectile dysfunction, extremely common with age. There's so many things that cause erectile dysfunction that are completely unrelated to Parkinson's disease, but it's very, very treatable. So I think it's something that, again, if you're know somebody or you yourself are concerned about these issues, it's worth coming in and just having a talk and seeing if there's anything we can do. There's also, premature ejaculation is also a common sexual disorder that I see really in all age ranges. And again, there's treatments for these. Some of these are medications, some of these are, behavioral sexual therapy, things like that. And I think, a lot of people think as urologists, we only address, men's sexual health, but I'll tell you that we also sort of are under the purview of female sexual health as well. And so these are kind of some of the symptoms that women might have with age. A lot of these can be related to hormonal changes, so lack of estrogen or low estrogen as we age. I'll talk about kind of in the next slide, low testosterone. These are extremely common things, and I think a lot of times they're a little bit under addressed and a little bit sort of under screened for in sort of the community. So I think it's worth knowing about them and seeing if you have these symptoms, is there something that can be done? Not all the time, but a lot of times there are medications, treatments that can be helpful. Then my last slide is just focused on hypogonadism or low testosterone. This is extremely common, and I bet if you just kind of read this symptom list to anybody, pretty much everyone's got one of these, I think. It's very non-specific, and it's not that everybody is going to benefit from screening and treatment, but there are a lot of patients out there that will. So it's really as simple as a series of lab tests and potentially thinking about, whether supplementing testosterone can be helpful. It's, again, not going to be a slam dunk. You're not going to, become a new person, but a lot of times, what I find in patients is they find they have quite a bit more energy, quite a bit more motivation, and the sexual function sort of gets revitalized a little bit. They sort of feel that effect. So I think there's a lot of benefit there, and something that I'm fairly, I believe that we're sort of under-treating in society right now. The other thing is that it may actually affect both men and women. So testosterone is sort of traditionally thought of a male sexual hormone, but actually women have testosterone as well, and the same benefits to men are actually the same things that occur in women. So a lot of women that are presenting with sort of sexual dysfunction can really potentially benefit from even small doses of testosterone. Again, this is not something that's really mainstream, but it's something that I think is very important to know about. And then finally, there's some data. There was a JAMA article some time ago that just suggested that testosterone should be safe in the Parkinson's population. So there's no reason to believe that prescribing testosterone to somebody would actually cause any harm, especially as it relates to these diseases. So yeah, that's my plug for that. I think it's one of those things that, again, it's just a little bit under talked about. That's really my last slide. So thanks for humoring me and listening to some of these points. I do really appreciate the questions, and hopefully you learned a little bit.
Thank you for sharing everything that you shared. I think all of it was important. Thank you.
Not a
There's
problem.
a question online about the testosterone.
Yes.
Is that pills or shots?
So testosterone is, go back to this one here. Testosterone can be supplemented in many different ways. Probably the one that most people are familiar with is going to be shots. So it's intramuscular. It's basically a needle you stab into your thigh once a week. But there's also creams and gels out there as well. So you basically put it on kind of your chest, shoulder, or thigh, just absorbs through the skin. So that's a very non-invasive way to potentially give testosterone. And then the one that I like the most is actually hormone pellets. So we actually put pellets kind of in the butt or the flank area that kind of release slowly over time. So lots of different ways of supplementing or prescribing testosterone. And I think they all have their own pros and cons. And with testosterone, it is important that we monitor labs. There are side effects, and there are certainly a lot of things to talk about, risks that are real risks with testosterone. So that's one where I think having a conversation with your doctor is very important. And that could be started, even with your primary care doctor. They would be the ones that could do the screening and talk to you a little bit about that.
But any other questions here in the room? Any other questions on Zoom? Okay, with that, thank you so much, Dr. Tam.